group, because these babies can be incredibly sick and difficult to manage, are babies who have got underlying metabolic conditions or endocrine conditions. And they'll come with other signs and symptoms that hopefully will make you think about an underlying cause. But it's important to be aware that they're rare. But if we don't think about them, then we won't diagnose or start the management effectively straight from A&E. So how would we manage a baby that comes into A&E department with a low blood glucose? Well, in the first instance, I think I call it anticipation, really. So you obviously know who your at-risk baby is. So if a blood glucose measurement hasn't been done, then it's important for you to ask for that to be done as part of the vital signs and triaging the baby. Once you have got your blood glucose, the question then you need to ask yourself is the baby well with normal vital signs, or is the baby unwell? Because obviously ABC will always trump the D, which is the dextrose. So it's important to make sure that the baby is well. But it's also important that as you're thinking about that you are thinking of taking steps to get the blood glucose level up. Because as we said earlier, hypoglycemia can result in significant brain injury if it's not correctly and promptly managed. So it goes hand in hand. You're thinking of a way of getting that blood glucose level up, as well as thinking what the underlying problem could be so that you can effectively manage this baby. So if your baby is well and you've taken simple steps to get the blood glucose up, perhaps a dextrogel or a feed, then it's important to try and take a quick focused history from the mother, the carer, the parent. It's also important, if you can, to look at the red book, because mothers would have brought the red book in, and just get an idea of what the birth history, the pregnancy has been. And then also you need to plot your baby on a growth chart. It's easy to do if you've got the Neonate app. Some of you already be using that, or you can see it in the red book as well. So if your baby is below the third centile, that's our definition of IGR, then that is a baby that you probably have to have a much higher threshold for managing. So that's why that is important. So having taken a quick antenatal pregnancy history, you then want to get a feeding history. And it's important that you get a clear idea of what this baby is taking. So it's not enough to sort of say to mom, for instance, is baby feeding okay? So it's get more details. How often is baby feeding? How much milk is baby taking? If baby is breastfeeding, how often is baby going to the breast? Does mom feel that her milk is coming, that her breasts are full? Is baby passing urine often? So wet nappies. How many times are you having to change the nappies? Are they dry? So find out if baby is waking up for feeds. Don't ask if baby's sleepy, because newborn babies sleep. That's what they do. That is in their job plan. So is baby waking up for feeds? Or is mom having to prod baby and baby just falls asleep at the breast, or when baby's bottle feeding? I want to stress that if baby is unwell or has abnormal vital signs, that it's important then to not focus on taking the history, but to manage the baby appropriately. So infection is always at the top of our list. As neonatologists, we're famous for giving antibiotics. So I think it's important then, as you're managing the blood glucose, and you're unlikely then to be able to do that by giving the baby a feed, you will need to give intravenous glucose, particularly if the baby's blood glucose levels are very low, or if the baby's having seizures, or looks really unwell. So as you put in your IV cannula, get some blood cultures and ask for some antibiotics to be given. The sooner they're given, the better. Worst case situation, it's not sepsis and we stop the antibiotics. But if this is infection, getting the antibiotics in early is vital. So I can't overstate that. So you go back to your history if baby is well and your mother's given a feed, or you've taken steps to get the blood glucose up with dextrogel or something like that. And then once you've taken your history, quick, and I call it top to toe examination of baby is important then, starting from the fontanelle and going right down. So what you do normally when you examine a child or baby. So further management of the baby with hypoglycemia will depend on the risk factors that you've identified, your assessment of the baby, if baby is well or unwell, how promptly the blood glucose levels have come up, because you will repeat your blood glucose after you have tried to get it up. And then if it's a simple issue like a baby not feeding, well, clearly mother needs feeding advice and support. And if you can arrange that in the A&E department, then that's fine. If not, you would need to refer the baby on then to your neonatal counterparts, and that baby can be seen in the postnatal ward or transitional care. It may be that the mom needs to be admitted with baby. So that can be easily done. If it's a baby who is unwell, particularly a baby with neurological symptoms, then that baby needs to be admitted. And if the baby is critically unwell, then obviously it needs to go to an ICU, to a pediatric pediatric intensive care unit. So your further management will depend on what your assessment of the baby is like. If the baby's blood glucose levels have not come up, then you'll need to think about whether this baby's got an underlying condition. And then you'd need to speak to someone senior about the referral pathways. I think it's important wherever you work to look at your local guidelines and use the referral pathways, because it will vary from hospital to hospital. Very quickly, if you are discharging the baby from the A&E department, do remember that safety netting is important. So ensure that there's some support for this mother. That can come from the community midwifery team if the baby is less than 7 days, or the health visitor. Write in the red book and send a message to the GP, a quick summary of the baby's attendance in A&E, so that further support can be given to this family. So let's run through one or two case histories. A 2-day-old baby is brought in by her mum. Born at 37 weeks gestation, weighing 2.46 kilos. Mum has brought the baby in because the little girl has been crying inconsolably. As part of her triage, she has a blood glucose measured, and it's 1.5 millimoles. How would you manage that baby? Mom's been breastfeeding. She says on demand. She's not sure if her milk has come in. She's a bit frazzled. So when you take a quick history, you realize this is a first-time mom. The midwife has not been in and she's not sure. She's got very little support. So you assess this baby. Baby's really well, and it actually just looks like a straightforward feeding issue. Luckily, you have a breastfeeding counselor. So baby has a breastfeed observed by the breastfeeding counselor, and the repeat blood glucose is 2.1 millimole per liter. Do you think this baby is safe for discharge? Did you spot that the baby was 2.46 kilograms? So that baby is small for her gestational age and is at risk of further hypoglycemia episodes. So although the blood glucose level looks like it's coming up, mom is feeling a little bit better about the feeding. This is a baby that needs more support and more monitoring. So perhaps this is a baby that you should be speaking to your neonatal counterpart and getting admitted to the postnatal ward with mum, where the breastfeeding can continue to be supported, but the blood glucose measurements can be monitored for the next 24 hours at least. So our second case history, a baby is brought in by the paramedics to A&E. You're told that the gestation is 36 weeks. Baby weighs 3.1 kilograms, was an unplanned delivery at home. Baby was said to have cried immediately, was wrapped. The paramedics brought baby in. Baby at triage has an unrecordable body temperature and a blood glucose measurement of 0.8 millimoles per liter. How would you manage this baby? So clearly this baby is profoundly hypothermic. And it's no surprise that the blood glucose levels are so low. The baby is also moderately preterm. So again, will have reduced stores or may have reduced stores. So in managing this baby, it's important to get the body temperature up, but also to get the blood glucose levels up very quickly. So this baby will likely need intravenous glucose administration, perhaps with a bolus of 2.5 mils per kilo, and then to start a 10% dextrose infusions going up while baby is being warmed. And then you assess baby and get the rest of the history and decide if this is a baby that needs to have antibiotics, etc. So it's important in this instance that this is not an early feed because the glucose level is profoundly low, but also because this baby is also moderately preterm. So you have multiple risk factors. So in summary, neonatal hypoglycemia is a common occurrence, and the causes a lot of the time are simple and easy to remedy. But it is also true that neonatal hypoglycemia can result in profound brain injury and can be catastrophic for families. So it is important that you're aware of the risk factors and how to manage hypoglycemia effectively in your departments. Always refer to your local guidelines and use the local referral pathways. Thank you.
Learned so much from that talk, and looking at the poll results as well. So 2.6 is like our magic pediatric number.
That's the magic number, isn't it?
Yeah, and I can see from the polls that's what most people count as hypoglycemia. So I think it's good to hear that that's not really, that things are changing and should be changing. I can see some people have 2.6 as a guide, but don't really worry unless it's 2 kind of thing. So do you know, what do you use in your place?
So we go with 2.6. That's what our current guideline says. But I think it was really interesting, the points around like, is the baby symptomatic? Because if they're hypoglycemic and symptomatic with it, it's slightly different from just being a hypoglycemic, well-looking baby.
Yep. And how do you feel about the use of the phrase BMs?
So I've worked in various places where some people loathe that, and yet at the moment, everywhere the people that I work with, we normally use BMs.
Yeah,
so
it's hard because as has been rightly pointed out by Simon Carley, that BMs is, of course, the manufacturer name of the company that made a particular type of stick. I can't remember how long ago it was. I have the 80s in my head, but I'm sure someone will know. And it's just stuck because it's like catchy, and then now it's become a term for a blood sugar. But it's it is the company name. And so some people have a real bee in their bonnet about it because of that. And so correct people often. I can see Becky and Simon Carley both not fans of BMs, I'm more on the live and let live side. But I can see that it needs to mean the same thing to everyone.
And that's the thing, isn't it? Lots of these acronyms, you can chuck in a random acronym and you know what it means, but no one else does.
Yes.
I've seen a BSL, blood sugar level, as well. That's another confusing one. Yeah,
I think BSL is quite common. And that's definitely, I try and avoid saying BM for all the reasons mentioned, but I know it's kind of a hard thing to break. It's amazing marketing, really, that they've managed to keep that going.
Incredible.
It really is. Okay, so next up we have got a panel and a talk. So the topic is going to be seizures, so neonatal seizures. Also, we see reasonably common different types of seizures, can be pretty stressful working out what's normal, what's not, what we need to worry about. So we've got a presentation by Ben on seizures, and then we have our expert panel here where we have a neonatologist, a neurologist, and a PEM physician. So it's pretty good combination, and so that's going to be exciting. We're also live streaming this session, so there's some people watching on YouTube, Facebook, Twitter, as well as Hopin. So I hope I don't mess up the tech. That's all I can say.
It's going to be fine.
So now we're going to go to Ben Lawton on seizures.
Good morning from a hot and rainy Brisbane. And the next few minutes, I'm going to talk you through my approach to seizures in the neonatal population. And really, my approach to seizures in neonates consists of three questions. Question number one is it a seizure? Question number two is there something wrong with the environment that the brain's in? And question number three is it a plumbing or an electrical problem, if indeed it is a problem with the brain itself? So we're then going to look at a management algorithm, and I'll use Queensland's as an example to see how that three-stage thought process is reflected in the management algorithm there. So question number one is it a seizure? And this can be a little bit more difficult than it sounds, because seizures in neonates can take four forms. They can be tonic, clonic, myoclonic, or subtle, and they're actually subtle in about 50% of cases, probably a bit more than that in term babies and maybe a little bit less in prems. And these are pretty much what they say on the tin. They are subtle. So they can look like eyelid flutters or eye deviation, like fixed staring, or like stereotype motions, like chewing or tongue thrusting or cycling or something like that. And you sometimes see memes floating around on social media of babies doing things that are clearly not developmentally typical. And I sometimes worry that these are actually neonatal seizures in disguise. It's important to be aware of subtle presentations because these are often missed by both parents and healthcare professionals for quite a while. So it's important to have a really good look at babies and have a particular good look at their eyes, at their gaze. Do they have any dysmorphism or birthmarks or microcephaly or other features that you're going to find on general exam that are going to make them more prone to a primary seizure disorders? It's also completely reasonable, I think, to observe babies for reasonable periods of time if you're not sure if the behaviour that they're exhibiting is a seizure or not, because it's not always entirely clear. Now, there are a couple of common mimics that are worth knowing about, and the first of those is jitteriness. It's quite common for babies to be a bit jittery. The jitters sort of consist of trembling and it can be in one or more limbs, but importantly, it doesn't affect the face. So the face involved is not the jitters. Jitteriness will also suppress with touch, and the classic way of doing that is passive flexion of one of the involved limbs. So if you flex the jittering limb, the trembling in it should stop, if it's indeed not a seizure. Now, the jitters themselves are not a seizure disorder, but they may have underlying causes that are consistent with some other seizure disorders. So they can be associated with drug withdrawal or electrolyte problems as well. So if the baby's particularly jittery, or if this goes on for a long time, you might need to do some more investigation anyway. The other big one that I think we see quite frequently is benign neonatal sleep myoclonus. And again, this is pretty much what it says on the tin, where it's benign, it happens in neonates, happens when they're asleep, and it consists of myoclonic jerks. It can be isolated to a single limb. More commonly, it's in more than one limb, usually the arms, and it happens during slow wave sleep. So you get this pattern of myoclonic jerks just after a baby's gone to sleep. A couple of really important features of benign neonatal sleep myoclonus is that it'll never happen when the baby's awake. And when the baby is awake, they should be completely neurologically typical. Once we've established that it is a seizure, question number 2 is there something wrong with the environment that the brain's in? And this is typically biochemical problems. So these sorts of things are particularly common in the first few days of life because a lot of things happen at birth. The baby's just lost its get out of jail free card of the placenta that's been looking after it for the last 9 months, and it's getting the first real systems test of its metabolic pathways and its ability to manage its own electrolytes. This is also the first time that a baby's been without any medication that mum's been on. So neonatal abstinence is something else that might appear around this time. Infections can also cause a change in the environment that the brain's in, particularly meningitis. And they may be apparent immediately, or they may need a little bit of incubation time before they start to affect the environment enough really to trigger those neurological signs that we're going to see as seizures. So the priority for investigations of a seizure disorder in a neonate is to find and fix any environmental issues that are going to do ongoing damage to the brain, because we want to cut that tap off as soon as we possibly can. That kind of drives the investigation plan that we're going to make around seizing neonates. We're going to look for biochemical environment, so blood sugars and electrolytes, remembering calcium and magnesium. A venous blood gas is going to give you a lot of clues about metabolic problems, and we're going to pay attention to the lactate on that. And an ammonia can also be very useful if you're worried about a metabolic cause. Importantly, I think a normal sugar, lactate and ammonia in the context of a symptomatic infant really strongly suggests that the cause isn't metabolic. In fact, it's a bit of a crude, dirty test, but I kind of think of metabolic disorders like broken rails on the London Underground. And I think those maps of the metabolic pathways of the human body that you see, posters and in books, kind of remind me of a London Underground map. And if you think about a broken rail somewhere on the Underground network, it's sort of fairly obvious what the consequences of that broken rail are going to be. The trains are going to pile up behind the broken rail and there won't be any trains downstream. Now, by investigating, by looking at a lactate, a sugar and an ammonia, really we're doing something analogous to checking the flow of trains at like Gloucester Road Bank and King's Cross. So some major crossover points on the network, and kind of assuming from the fact that the trains are flowing normally there, that everything else is working normally elsewhere. Now, if they're abnormal, there aren't any trains coming through Gloucester Road, then the other metabolic investigations that we do are really looking at more detail throughout the pathways behind so that we can localise that problem a little bit more closely. But if everything's running normally, you'll get a normal lactate, normal ammonia and normal sugar. We're also going to look for infection. That's a common cause of seizures in neonates. So normal infection investigations, full blood count, inflammatory markers, some cultures and some viral PCRs. As in any neonatal concern for infection, it's reasonable to shoot from the hip with antibiotics and follow the local guidelines for meningitis. I think it's important to remember herpes, and I'm pretty keen on starting acyclovir really in every baby that's seizing until we've proven that it's not herpes. PCOM recently did a study that showed that herpes was more common in their data set as a cause of infant meningitis than listeria was. And I think we're quite good at remembering the ampicillin and the amoxil, but not always so good at remembering the acyclovir. An LP is going to be indicated, but the timing for that's really going to depend on the clinical state of the baby, and you certainly don't want to withhold antibiotics in the meantime. It's also worth a word about vitamin deficiencies, and pyridoxine particularly. So pyridoxine deficiency is a cause of intractable neonatal seizures, which is usually reversible, often reversible with treatment with pyridoxine. So if you're working your way down the algorithm, pyridoxine's a reasonable thing to consider at some point. So if we've decided that it is a seizure, and we've decided that the environment's okay, or at least we've started investigations for environmental problems, then we're thinking about primary brain problems. And primary brain problems to me can be in two categories. They can be a plumbing problem or an electricity problem, representing vascular problems or primary epilepsies themselves. Plumbing problems are the most common cause, and that would be HYPOXIC-ISCHAEMIC encephalopathy, most commonly in term babies, which really represents a lack of delivery of oxygen at some point in the developmental process, or intraventricular hemorrhage, which is the most common cause in prems, and that represents leaky pipes or blood where it shouldn't be. It's unlikely in emergency that we're going to see either of these as primary presentations, because they'll usually be picked up before discharge from the perinatal ward, but that doesn't always happen, so it is worth bearing in mind, because they are leading causes of seizures in that age group. The other plumbing problem, the other vascular cause that's worth thinking about in the neonatal age group is perinatal strokes. The seizures are the most common presenting feature of this. Now, I think perinatal stroke's quite a difficult diagnosis often, and it will need imaging really to identify it. So that imaging can be urgent if that's high up your list of causes. What imaging you're going to do is going to depend a bit on what you're looking for and a bit on what you have access to. So we're mostly looking for plumbing problems with imaging, but MRI might give us some features that are consistent with electrical problems as well. MRI is going to be the most useful test and really will be needed at some point in a seizing neonate that we don't have an obvious underlying metabolic cause for, and even many of those that we do actually, but it can take a little while to get. Ultrasound is a helpful, quick and dirty screen and can reassure you that there's not a head full of blood, but it doesn't have the sensitivity to preclude the need for MRI. And CT really is just for making sure that you don't need a neurosurgeon quicker than you can get an MRI. For CT is good for looking at vascular problems, and most of us have more ready access to that than we do to an MRI scanner. Non-accidental injury is possible in any baby, particularly those babies that have left the hospital, and it's worth bearing that in mind when you're deciding against a CT. So if you're not sure what's going on, it is worth considering imaging to exclude a bleed secondary to NAI, because that won't be evident from the history. Now, electrical problems are really where we need to get out the big paediatric neurology textbook, or more realistically, phone a friend, call Matt. But there are a huge number and variety of genetic epilepsy symptoms, and the prognosis for them is generally, unfortunately, not very good. The treatment, and certainly the empiric treatment at this stage, is relying on a fairly light evidence base, and that translates into quite a big variety of guideline-based treatment, and many options being given, as we'll see in the Queen's guideline. So Queensland's guideline, as you can see, starts with this first decision box, which is this seizure activity? And it gives you a few pointers as to how you might tell if it is indeed a seizure. Then there's a second box, can an underlying cause be treated with immediate effect? And that's really talking about those environmental things that we were discussing a little bit earlier. Because it's really worth noting that there is no point in giving anti-epileptic drugs without fixing an underlying environmental problem. It then suggests a loading dose of phenobarbital if the baby's still seizing, and indeed PYRIDOXINE if they're still seizing after that phenobarbital, and then really offers you this massive selection of second-line anti-epileptics, really reflecting that fact that there isn't very much evidence for any single second-line agent in neonatal seizures as an empiric agent. So, in summary, my approach to neonatal seizures involves 3 stages. Each of those stages has got a question. So we're going to ask 3 questions. Question number 1, is it a seizure? Question number 2, is there a problem with the environment the brain's in? And question number 3, once we've established it's a problem with the brain itself, is it a plumbing problem or an electrical problem? Now we're going to have a little more of a chat about that just now. Okay, so we're back in real life, and I'm lucky to be joined by Jasmine Antoine, consultant neonatologist, and Matt Lynch, who is a consultant paediatric neurologist and metabolic physician here in Brisbane with me. And I'm going to ask them the trickier parts, I guess, of the things that we covered in the talk just then. So, Jazz, can I start off with you? Now, that Queensland guideline, I think, has it leaves you with quite a lot of leeway as to what you can choose. It suggests some phenobarbital first up, and then there's lots of things to choose from after that. In your real life NICU, what's your real life approach to neonatal seizures?
Yeah, thanks, Ben. I think one of the common things that we do go to first is phenobarbital. There's always a consideration for babies, what are the side effect panel with that medication, and are we worried about their respiratory status, and something to consider when you're giving them a load. And definitely when we're coordinating retrievals, we always, want to think about that as well. And then if there's ongoing seizures, we often give another load in the neonatal intensive care unit. That might be different for you guys in ED or in general pediatrics, but we have a bit more of a controlled environment. And then we move on to Keppra usually. And babies that have status, which we probably see most commonly in my population, in those babies that have severe HIE, we often then move on to a midazolam infusion. So as you said, a little bit different to the guideline, and there's a couple of different options on that guideline for, second and then further treatment after that. The other thing we always do when we're getting onto our second or third treatment is talk to our friendly colleagues. So I usually pick up the phone and talk to Matt or his colleagues that are on call for neurology, and just kind of get their advice as well, and if any additional treatment.
Awesome. So generally phenobarb first, and then Keppra after that.
Yeah.
Matt,
And we generally give a
go on,
couple
sorry.
of doses. Yeah, we generally give a couple of doses of phenobarbital before we move on to a second agent.
Do you see any hemodynamic side effects or any other problems with second doses of phenobarbital?
Yeah, sometimes. Definitely with a bigger load of phenobarbital, probably the most common side effect that we'll see is respiratory depression. So, being in an environment where you're able to manage the airway is important. And then the other side effect that we commonly see, well, not commonly see, but, the next kind of most common side effect would be hypotension. So, I'm in the right place to manage both of those things, so it's fine for me. So often we, give that first and second load.
Yeah, no, that makes a lot of sense. Now, Matt, one of the things that I think is a little bit tricky sometimes is that we see more, certainly in my environment in ED, we see more seizures in older kids than we do in neonates. In the older kids, we tend to use phenytoin or Keppra as a first-line agent. And when we're getting down to looking at the neonatal guideline in Queensland, phenobarb's obviously the first-line agent. Why is phenobarb the first line in neonates?
Well, Ben, it's great. It's probably the most studied drug in the neonatal population in terms of seizures historically. And so phenobarbital's got a very good understanding of pharmacokinetics and how it interacts with various bits and pieces. And as you alluded to in your talk, there's actually been a relative paucity of evidence across the board for which is the best drug, after midazolam for bolusine in terms of controlling neonatal seizures. And there's been very few randomised and head-to-head trials that have been done. And one of those ones, which is about 20 years old now, was the phenobarbital versus phenytoin for acute provoked or acute symptomatic seizures. And what they found in that group was, in that study, that the efficacy in terms of controlling seizure burden was roughly the same. I think both groups were about 50% responders, but that phenytoin did carry some additional hemodynamic side effects that wasn't seen as prominently in the phenobarbital group. And as one of my mentors always told me, phenobarbital's an oldie, but it's a goodie in terms of really making it's one of those ones we've used forever and people feel very, very comfortable with. And then Keppra has come along like the new kid on the block, really, and increasingly has been looking for a place in status algorithms across the age groups, and including neonatal seizures. And there was really only small case series and reports to try and guide its use of how did it stack up against phenobarbital until Cynthia Sharp's group put out the NeoLEV-2 study data about 2 years ago now, which was really quite striking in the difference in terms of as a direct head-to-head comparator for largely, again, acute provoked seizures, and showed that in terms of seizure control efficacy, that phenobarbital had a much higher responder rate as a single drug compared with Keppra.
Excellent. So there's some historical data and some experience, but it's certainly not being contradicted by anything that we're finding now.
We can never go against our mentors, and when they say it's an oldie but goodie, we just say yes, sir.
So, you've mentioned Keppra. Now, with certainly with ESET coming after Concept and Eclipse, and I think NeoLEV as well, the dose that we've been using for Keppra in guidelines and in real life seems to have been creeping up and up and up and up. Can you share some thoughts about dosing of Keppra? How much should we be using?
I think we're still trying to work that out, Ben. And we saw with the older kids coming through that when it was first used, people were using somewhere between 20 to 70 milligrams per kilogram as a loading dose in multiple reiterations and multiple bolus formats. And the same with, even when we look at the recent NeoLEV-2 study, their Keppra arm started with 40 milligrams per kilo within a subsequent 20. And even within local practice, some people will now just start with 60 because there was a small group who was additional responders in terms of using both of those dosing together before crossover. So it's still, no one really knows exactly what the dose is. I mean, some of the studies have had varying degrees of what dose of Keppra they've used across the park, from low as 10 to 20 milligrams per kilo, then beyond up towards 200 milligrams per kilo in some. And what we know is that babies will eat Keppra like breath mints and not really think too much about it otherwise, without these really profound hemodynamic drugs that we see in, you know, some of the more traditional agents like phenobarbital that we've been using. So the honest answer is nobody knows. A lot of the guidelines say 40 per kilo. A lot of people's personal practice will say comfortably 60 milligrams per kilo as a bolus, and hopefully over time we'll all get, you know, more data and more experience and knowing where to start.
Excellent. So it certainly does have some of those practical advantages, hey, and a safer window, and like the babies chew it up like breath mints. That's a good takeaway tip, I think. Awesome. Jazz, you mentioned that we obviously spoke about the Queensland guideline a little bit, and you described your practice of giving phenobarbital and then a second dose of phenobarb and then some Keppra. Do you see anything? Are you aware of anything? Is there anything on the horizon in terms of trials that are going to consolidate practice changes in this area, or are we looking at guessing for a long time to come?
Yeah, I don't know of anything upcoming related to, you know, medication dose related that's upcoming. Really, the studies that we're seeing in this area now, the most recent one, which has just finished getting all, you know, recruiting everybody, is the PN trial, which was looking at EPO and having a look at the impact of that of babies with moderate or severe HIE and the long-term, you know, neurodevelopmental outcomes. So they've just finished recruiting for that, and data will probably be out, you know, in 2 to 3 years. But I don't really know any upcoming seizure, like medication or management studies. I don't know, Matt, if you...
The main one that is starting now or recruiting is there's a trial for IV lacosamide, so an alternative sodium channel blocker for refractory electrographic neonatal seizures. So it's really, Jazz, the biggest population you guys would have in terms of those acute provoked seizures. We've got experience in older kids in terms of, you know, started with adults and worked back, but in terms of there's another good loading agent, but again, we haven't got any data to support it. We think it'll be fine in neonates, but again, that's coming out in terms of looking for that. But, and again, on the horizon, agree, there's not a lot new that's coming out at the moment. There's a lot of in the neonatal units, there's more in the ways of, you know, the AEG setup studies in terms of looking at seizure burden and seizure detection systems, but on a treatment front, there's not a lot at the moment.
Yeah, I would agree. The NEST trial wrapped up, you know, and the results came out last year about that. So that was a comparison of whether we should treat clinical versus clinical and electrographic seizures, and then what were the long-term outcomes, and did that have an impact on your changes on MRI and your neurodevelopmental outcomes? And there was no significant difference in the groups. So I suppose there are a lot of units that still have babies on AEGs, and there are some units that I've worked in that don't, and they just treat clinical seizures. And, you know, the real main practice changes that we've had, I would say probably in the last 5 or so years, have been more a focus on not missing the moderate and severe HIEs, because obviously in my population, HIE is, you know, the most common cause of seizures. So there has been a lot of work on, you know, doing trigger tools and things, so babies get reviewed hourly for that first 6 hours, so you're not going to miss your cooling window. I think that's probably been the main practice change that I've seen in the nursery in the last 5 years, yeah.
Can I ask you just a little bit more about HIE? Because you mentioned that's one of the leading causes of seizures in babies that you see. Is that something that you would really, is that something that we need to be looking for in ED as well? Is that something that really is going to be picked up before babies go home? Or what should we be looking for in that regard?
Yeah, hopefully not in ED, but unfortunately we still do miss a percentage of moderate to severe HIEs, and babies, you know, still die from HIE. So hopefully you won't be seeing it represent to ED, because the babies would have exhibited signs, you know, within that first 24 hours. You know, the majority of our babies born in hospital will remain in hospital for the first 24 hours. There are a percentage of babies that will go home within that 6 hour to get their 6 hour check and be out the door with their parents. So there's the potential for them to represent, but that would be really unlikely, because, you know, we expect those babies to have HIE that have had a critical event. So they normally exhibit that by needing resuscitation at birth. So you're not going to go home at 6 hours if you needed a lot of resus at birth. The babies that are really acidotic and have abnormal, cord gases is another criteria for, getting you into the cooling pathway. And not every hospital will obviously do cord gases, but the babies, if they're really acidotic to hit those thresholds, will look unwell for, a period of time. It's not like you go from acidotic to well to out the door in 6 hours. So hopefully, they won't be representing, but we do unfortunately miss some still that get admitted to the nursery outside of that cooling window, but I would say that they get admitted to the nursery within the first 24 hours.
Right. No, that's good. I've got a quick question online, and we've been talking about phenobarbital as the first line agent, but we've been talking about it in terms of a single load or a second load. Somebody's asked what doses do we use, because they found guidelines that are mentioning loading doses ranging from 20 to 40 milligrams per kilogram. Do you know, Jazz, off the top of your head, what you use in your environment?
Yeah, it kind of depends where they are. So if I've got an inpatient, I'd start with a 20 milligram per kilo load. If I've got a retrieval out in the middle of nowhere with rural generalist looking after a baby and they're the only doctor on site, we often would start with a 10 milligram per kilo, but that will vary, amongst whoever's on the end of the phone. But yes, we commonly do go up to a total of 30 or 40 before adding in a second agent.
Cool. Yeah, no, I must admit my go-to off the top of my head would have been 20 milligrams per kilogram, but I don't know how much of that is just convenience, because that's what many anti-epileptics seem to come in. Matt, have you got any thoughts, Matt, about the dosing of phenobarbital? What should the initial loading dose be, do you think?
It depends if you've been intubated by your friendly neurologist lately or by a neonatologist. No, it's the standard for us, similar to the Jazz, is 20 milligrams per kilo with then a subsequent 10 to 20 up to 40 as a total milligram per kilogram loading dose. That would be our standard practice, in keeping with what people both in emergency and neonatology do as well. And that would, regardless of whether on the ward or an ICU, that would be our standard.
Yeah, cool, excellent. That's good. Matt, can I ask you, we touched briefly on pyridoxine in the talk earlier. Can I ask you to tell us a little bit about pyridoxine, pyridoxal 5-phosphate, and what do they do basically, and should we be giving them to everybody?
It's my favourite topic, Ben. I guess one of the take-homes for these vitamin-dependent epilepsies, and they're the two big groups you spoke about, is one is pyridoxine, and the big group for that is, it's the rare, but antiquidin deficiency is the genetic disorder most associated with pyridoxine-dependent epilepsy. These are kids who really they've got unexpected, severe, and drug-resistant epilepsy is the sort of take-home message in terms of how they present. So it's quite unexpected. There isn't this antecedent history of suspected hypoxia or other obvious causes, and so it's really the big causes, like from what people both in ED and neonatology will see, is those acute provoked seizures. So it's really the two big groups, HIE and then the vascular ones, and then infections thrown in on top of it. And genetic and metabolic are obviously uncommon causes even within this subgroup, but that's the first flag, is it can be unexpected, and they can have surprising systemic manifestations within it, because these are cofactors for like pyridoxal 5-phosphate is a cofactor for over 100 different enzymatic reactions in the body, which include both CSF neurotransmitter production through to more hepatic function. And so it's actually quite common to see things like acidosis when they present, and these other peripheral signs that aren't purely neurological in terms of that. And so really, if you've got this unsurprising picture of epilepsy, in a very early onset neonatal epilepsy, and you've failed multiple drugs, and there's some other clues that often come up in terms of, for us, in terms of often these babies go into EEG and they've got very severe pictures of things like burst suppression and global cortical dysfunction, really, that's out of keeping with the rest of their presentation. And so place to place is a little bit different in terms of how you've moved through your benzophenobarbital Keppra algorithm, and then you find yourself at this, this patchy area that people are uncommonly in, which is starting to throw around some vitamins. And even internationally, nationally, there's varying practices on that. So pyridoxine will only treat, pyridoxine is vitamin B6, and so things such as pyridoxine-dependent epilepsy or antiquinone deficiency are responsive to that. But PNPO is a different enzyme in the vitamin B6 pathway, so it actually doesn't respond to IV pyridoxine. You need pyridoxal 5-phosphate, which is only an enteral formulation. And the other backward way about thinking of it is if you respond to pyridoxine, they all respond to pyridoxal 5-phosphate as well. And so there's some units that will try IV pyridoxine first, and then if you've got failure after a time frame, which is often about 24 hours, you'll then substitute it with pyridoxal 5-phosphate. But even that mark of improvement can be a little bit difficult there. And one practical thing around, I guess, pyridoxine administration is the babies who truly respond to pyridoxine, it creates this overwhelming picture as a response, and one of the manifestations of that can be profound apnea. And so if they aren't intubated before that, there's a very good chance that they might need to be intubated from a true response to pyridoxine. So that's just one of those practical things around it. The other important thing that's good for people to know is these are uncommon situations. Even for us, we find ourselves, it's not that common a presentation that we see, but there's no medications that you will give that will then potentially mask either a biochemical marker that may be diagnostic down the track. So there's no vitamin that you can't give that you should have done a test for first, in terms of just for people in crisis and going through that. It can all be worked out subsequently with diagnostic biochemistry or genetics.
But there's really no downside to giving this drug if you're
That's right.
Incorrect is if it's not related to if it's not a pyridoxine dependent seizure, then you're not going to cause any toxic effects. You're not going to cause any significant side effects. The risk of apnea is in the kids who are having a significant response. So you do need to be prepared for that, but it's kind of a win if you get that. Is that fair?
That's right, absolutely. So pyridoxine has no side effects in the acute. If you not respond to it, it's got no acute side effects, same as pyridoxal 5-phosphate while you're working through this. And there is one other medication I was just going to touch on in this pathway that I guess increasingly we're using more and earlier, and that's using sodium channel blockers like carbamazepine or oxcarbazepine. Everyone thinks, when we get to the refractory neonatal seizure pathway, that always looking at metabolic, and it's good to look at metabolic because they're treatable, and some of those ones will have by controlling the epilepsy with vitamins, you can have a positive response in terms of better developmental outcomes down the track. What we've found in recent years is that the biggest actual group in terms of these refractory neonatal epilepsies that aren't an acute, HIE type cause is actually you're more likely to have a genetic channelopathy, something like a KCNQ2 mutation, rather than metabolic cause of what's going on. And importantly, by just starting them on drugs like carbamazepine, is you can actually abolish their seizures from the get-go there. And so as a clinician, it's quite rewarding. How much we change the developmental outcome is unclear, and we're still waiting for more evidence around that. But I think it's just one of those important caveats that if we're cracking out the pyridoxine and the pyridoxal 5-phosphate, we probably should be thinking about at least is adding in some sodium channel drugs in terms of controlling the seizures of these more likely and more common genetic, like these channelopathy disorders.
Wow, that's awesome. So these are some of the things that you're thinking about when we're saying we're going to phone a friend when we've got to 2 drugs down the guideline. These are the kinds of things that you're thinking about.
Correct, but you can't take our 3 options away from us because that's all we've got.
Very good. Could I change tack a little bit and ask you, Jasmine? Now, one of the things that worries me, and I know quite a lot of colleagues in ED, is the fact that when neonates come in to us sick, we don't have a lot of opportunity to practice the procedural aspects of caring for them. Do you have any thoughts or advice about how we can both develop those skills in the first place and maintain the skills once they're there?
Yeah, I think those 2 points are good points. You've got to be able to develop the skills, and then it's difficult to maintain a skill that you do infrequently, right? So you probably need some other options as well. So with respect to, gathering the skills, I think if you're planning to be a general paediatrician regionally where you're going to see neonates, or, work in a mixed ED, doing some time in neonatology, preferably as a fellow, is a good idea, because it gives you a lot of hands-on experience, not just in decision making, but also in procedures. And you need to do a lot of procedures to become competent in it. And we see, even amongst our population of neonatal fellows that are going to become neonatologists, at the end of 2 or 3 years, sometimes they're still not particularly confident in certain procedures because we're not doing them as commonly. And one of the most ones we have issues with is probably neonatal intubation, which is probably something a lot of your colleagues, worry about as well. Because we're kind of moving towards more like non-invasive ventilation. So there's less opportunity to do intubations than there was, even when I was a registrar and we used to intubate everyone to suck out the meconium. We don't have those opportunities anymore as a junior registrar. So I think trying to spend as much time in the neonatal unit, if you're heading to Gen Peds or mixed ED, is a good thing. I'm not just spruiking neonatology that maybe we'll be able to convert you to the specialty. And then from respect of like trying to keep your skills up, I think an important thing is to know what equipment you have in your unit and where it is and get it out. And although simulation, is not the same as real life, simulation is really helpful. So, getting that equipment out, knowing what it feels like, knowing what you'll use without having to, there's a baby, that baby needs to be intubated. I don't know what tube size I should use. I don't know how far it should be in. And I suppose when we're doing procedures that we haven't done for a long time as well, having a kind of process in your mind around safety. So, like who's the best person in the unit at that time to be able to do it? Are you actually, just because, you're the consultant or the senior fellow, there might be someone that's just done 6 or 12 months of neonates that might have a lot more experience than you. So considering that and having a bailout point. I think we as paediatricians and definitely as neonatologists, we can get quite task focused and quite fixated on having a successful procedure, and get down on ourselves when we can't put an IV in or can't get a tube. But realistically, that's a baby, and we know that, especially with the extreme prems, the more attempts that you have, say, for intubation, poorer outcomes are related to that. So it's important to have like a bailout point, thinking about that continuously. I'm going to have 2 goes at this IV and then I'm going to go to somebody else. Yes, I'm the best person in the unit currently. And then, becoming familiar with that equipment, I think, is really important. I've been to lots of EDs when a baby's getting, extreme prem's been born at home in the toilet, they get brought in with the ambulance and we're kind of like pulling out the resuscitation cot, dusting it off as we're putting the baby on. So from a practical point of view, I think that's good to get that stuff checked regularly and know where it is.
Yeah, Ben, I'd like to go on record first and say I note that you didn't ask the neurologist how you keep your procedural skills.
We could ask you about LPs.
Very good. Yeah, no, it's a real challenge, isn't it? I certainly echo your thoughts about to get things out and use them, and it does just take that extra layer of cognitive load off when you're thinking about it. And I completely agree about the ability to stand around. Certainly the best experiences I've had, I think, doing critical procedures in neonates are when I've been able to stand around with a couple of senior colleagues and we've sort of been able to have a pretty comfortable discussion about who's most comfortable doing what and how we're able to help each other, and you can and I think you do get better results with that. So yeah, I think that's a great point.
And I think it's important not to focus like on the procedure, like focus on the outcome that you want. So, we definitely get very focused on we need to intubate this baby because it's an extreme prem, but do you actually need to intubate that baby? Can you just bag them for a couple of hours? Most of the time you definitely can. Like I've bagged a 23-weeker for a couple of hours waiting for retrieval as a junior registrar. So you can. So, don't try 6, 8, 10 times before the retrieval team gets there. If you're adequately bagging them, just continue doing that. And the same with, IV access. We would always say go to the UMBI in a fresh baby, that's less than a few days old. I know you guys in ED are probably more comfortable with an IO, but, don't keep persisting with that IV over and over and over again. move on to something else with somebody else.
Yeah, no, I think that's an awesome take. What's the line? Nobody dies from failure to intubate; they die from failure to oxygenate. It's
exactly
reassuring at the end of the day.
Yeah,
fantastic, awesome.
Yeah.
So go on, sorry.
I was just going to say, and like the crushing defeat on your ego will not kill you either, although it sometimes feels like that when you can't get a line in. It sure does. It sure does.
It's true. It's true. Wonderful. That's fantastic. So we're coming to the end of this session now, but Matt, Jazz, thank you so much for your time and for your wisdom this evening. Certainly I've learned a lot and there's some fantastic pearls in there. We're going to have a break now, and if it's currently 20 to 10 at night, it's 20 to something else, I'm sure, where many of you are. But we're going to come back in 15 minutes at 5 minutes to the hour. But go and make yourself a cup of tea and we'll see you again in 15 minutes or so.